Joel and Stephen have validated so much of what I'm going to say. I'm going to reinforce a lot of things that they've had to say. They did just a wonderful job describing the landscape that we're all practicing now. So, first of all, I want to talk about the current landscape that changed in March of 2016, and I'll go into the reasons why. And the reason I want to talk about the landscape is because it will help you understand what has driven, what has driven provider behavior, sometimes not in a positive way. And then I'm going to move on to talking about tools and tips about how to manage chronic pain in primary care setting. And then move on, and because the two are often linked, you know, we see a lot of people with chronic pain, and some of them bleed over into becoming addicted. And so there's a role for us in primary care of dealing with those, identifying those problems, and then dealing with them. And I'm also going to talk a little bit about how you incorporate a treatment program in a busy primary care practice where you may be seeing 25 or 30 patients in a day. And lastly, and this will sort of tie into the session for the afternoon, what are the solutions to the opioid epidemic? Where do we go from here? So, it's been said that 1 out of every 10 people that has a mental health disorder ever comes into the healthcare system. And 9 out of those 10 frequently treat themselves in inappropriate ways by using alcohol or drugs or sex or eating. Unfortunately, this is true in the physician population too. You know, you hear a lot about physician burnout. 60%, 65% of providers, particularly primary care providers, emergency room physicians, psychiatrists, are burned out. And I have had some discussions with a physician in a Mayo Clinic that is looking at this problem in residency training programs in their system. And of those 60%, and the same is true in the residency programs, of those 60% that are burned out, only about 15% seek training, and the rest self-medicate, which is really kind of a scary thing when you think about these as your providers. So a lot of people may not know this, but 60% of all mental health is dealt with in a primary care office. And a lot of times primary care becomes a default position for services that aren't available in a community. And mental health certainly is one of those. And a lot of times we come across problems that we've had to kind of pick up and learn on the fly. And that's true of lots of different problems that we deal with. 79% of all antidepressants that are written for in this country are written by primary care providers. And 40% of all narcotics that are written for in this country are written by primary care providers. So in 2015, there were more deaths from opioid overdose than patients dying from HIV infections at the height of the epidemic. In 2016, there are more deaths from opioid overdose than the total number of soldiers that were killed in Afghanistan and Iraq. When I saw those statistics, for the first time, it really hit me over the head of how big a problem we've got, you know, and it truly is an epidemic. And if you look outside the United States, you could say it's a pandemic. Historically, And Stephen talked about this a little bit, but I wanted to address, because I think it's hard to understand how we got to this point. Back in the 1990s, the Joint Commission of Accreditation for Healthcare Organizations talked about pain being the fifth vital sign. And the mantra was nobody was going to be in the hospital and have pain. And, we developed these scores, pain 0 to 10, and these smiley faces and faces that didn't look so good. The four vital signs were pulse, respiration, blood pressure, and temperature. And pain was added to that. Well, it was, looking back on it, it was really unrealistic to think that we should completely eliminate somebody's pain in the hospital. Following that, a few years later, the Institute of Medicine, which develops a lot of policy for us as clinicians, came out with a white paper that said pain is undertreated in America. And it gave some credibility for us to start using narcotics to treat pain in primary care settings, particularly non-malignant pain. Prior to this, it was fine, it still is fine to treat people that had cancer or end-of-life pain. So between 1997 and 2007, the average prescribed dose of opioids went from 100 milligrams to 700 milligrams of morphine equivalents. When I saw that, I just couldn't believe that number. And at the same time, the pharmaceutical industry started producing narcotics that were more and more potent. And the one that the poster child is OxyContin. And originally, OxyContin really did a good job of relieving pain. It was a long-acting preparation. I think it's garbage for us as people said we didn't know that this was such an addicting drug. I mean, we knew people can become dependent on drugs. It doesn't mean they're addicted. But it became a big player. And as it became a big player, the pharmaceutical industry, as they're wanting to do, they wanted to generate more profits, and they started increasing the price of the drug. And the price of the drug rose so dramatically that it was taken off of drug formularies. Well, that presented a really big problem for us because these people were dependent on those drugs. And then what do we replace it with? Well, one of the things that we ended up replacing it with, not everybody, but a number of physicians that really didn't understand the pharmacokinetics of methadone, used methadone because methadone had been around for years. Methadone is a great drug to treat addiction. I would tell you that in the hands of some people, it's an okay drug to treat pain, but I would stay away from it completely. Methadone was like, I don't know, $4 for, 10 days of medicine. I mean, it's really a cheap drug, so it became an alternative. So at that time, the poster child, the ground zero for opioid deaths and addiction was West Virginia. And it really came to light how big a problem this was around 2006. They had the highest death rate in the nation. A lot of the deaths occurred in people with low education levels and people that are in poverty. This was also the time when NAFTA came into effect, and where did all our jobs go? They went to, where did our blue-collar factory type jobs go? They went to Mexico, they went to China, Vietnam, India. And so a lot of these people in blue-collar jobs, undereducated, they had no way to make a living anymore. 95% of them when they were evaluated, had one or more indicators of drug or substance abuse. And 93% of the deaths were, opioids were implicated, and a number of those deaths involved methadone. In the state of North Carolina, at the time, methadone was the 17th most prescribed narcotic in North Carolina. But it was the #1 cause of accidental overdose. And the problem with methadone is that it has a pain relief peak of 5 to 6 hours, but it accumulates and has a half-life in the body of 18 to 24. So what happens, particularly when you saw people combining methadone with alcohol, anxiolytics, sleeping aids, it led them on a fast course or a faster course of respiratory depression and death. So something had to be done. By 2014 and 2015, the powers that be in the federal government said, you know, we've got to get a hold of this. We've got to form some kind of national policy to stop this. And there are a lot of, certainly a lot of fingers to point at who is to blame for all this, but it was just something that, you know, in sort of perfect storm happened and ground swelling, and, you know, we were in this scenario. So there were two advisory committees that put forth announcements. The one that got all the attention was the second one. The Centers for Disease Control launched the National Opioid Guidelines. And from that, North Carolina added onto it with the STOP Act. The one that didn't get any attention was the committee that announced a national pain strategy declaring pain as a significant public health problem. And part of the reason this was done is that people that had legitimate reasons for using narcotics were finding they couldn't get their narcotics anymore. In interpreting these guidelines and rolling them out to the community, we as clinicians got a lot of mixed messages. The STOP Act and a lot of the CDC guidelines were meant for acute pain, but they bled over and they were applied to people with chronic pain, and they were two completely different scenarios to treat. What the CDC guidelines try to do is help patients and keep them from going down that pathway that leads to addiction that Stephen has talked about. And they made good recommendations. You know, I know a lot of dentists in the area, for example, and we don't talk about dentists much. They pull a tooth and they give somebody 60 Percocet pills, and they maybe need 2. Or when people had surgery, you know, they'd get 50 or 60 oxycodone tablets, and they may have only needed 2 days of pain relief. Some didn't need any. And unfortunately, a lot of the people I've seen that have had substance abuse, they got it after having shoulder surgery, for example. And they were given 60 pills, and pretty soon the pain that they were using the medicine for was gone, but they were well on their way to an addiction. So the mixed messaging ended up creating a lot of limited access for narcotic medicine for people with chronic pain. In addition, the rules were applied to patients with chronic pain that were meant for patients with acute pain. And the administrative burden, for those of you that are practicing clinicians, the administrative burden to wade through getting drugs approved was just intolerable. And we have a lot of administrative burdens that we and our staff wade through every single day that just is tiring beyond belief. So what happened is a lot of primary care physicians said, you know, I'm out. I'm not going to prescribe any narcotics for anybody at any time. And one other thing I want to say, that there was actually some science. People ask me all the time, why did they pick 90 milligrams? You know, medicine is about titrating. If somebody has a blood pressure problem, and their blood pressure isn't controlled with one drug, then you move to another class and you add a drug and you add a third drug. Well, pain is about titrating too, particularly chronic pain. It's not so much a deal for acute pain. So, but the 90 milligram equivalent of morphine was used because in opioid naive patients, when you start moving over that milligram equivalent, you start seeing those way higher doses of respiratory depression and death. Now that's not true in the chronic pain set, who can tolerate higher doses. So there was some, science behind why they chose that. But it created a lot of confusion in the chronic pain community. So at the same time, once these guidelines got rolled out, one of the past presidents of the American Board of Pain Medicine took issue with the CDC's 90 milligram ceiling. And we were finding that chronic pain patients, in one study, 38% considered suicide because they were having increasing difficulty accessing their opioid therapy. And there was a perspective in the New England Journal of Medicine a year ago in February that was written by a pain medicine specialist in the Northeast. And in his metropolitan area, all the primary care physicians decided not to prescribe narcotics, anxiolytics, or sleep aids for anybody. If patients wanted those kind of medicines, they had to go to a pain clinic, a psychiatrist, but it wasn't going to happen in our office. And a lot of it was driven by the confusion, the mixed messages, the administrative burden that it was placing on offices. It was just easier not to do that. So the perspective basically was a plea begging that primary care physicians get back in the treatment mode for treating people with chronic pain. And here locally, part of the reason why we're having this conference today is that the health department in Caldwell County does a needs assessment for health every 2 years, and they interview about 800 people, patients, not providers. And they ask them, what are your perceived needs about what we're missing here? And the 4 things that came up the last time they did this, the first was lack of access to mental health facilities or providers. The second was lack of access to treatment for addiction. The third was, I believe, those 2 factors in adolescent community. And the fourth was lack of access to primary care services and preventative services, which I'm still trying to wrap my head around. I'm not sure exactly what they meant by that. But one of the other questions they asked is, if you were going to go out on the street, why would you go out on the street to buy a narcotic? And the number one answer was to treat pain. So pain continues to be undertreated in the United States, and you know, back in the 80s, it was really undertreated, and now we've come full circle and it's becoming undertreated again for different reasons. There's all sorts of discussions about who should manage pain. There's a shortage of chronic pain management programs in the United States. And when you pull the primary care set away from that, it becomes just a crisis. And then a lot of primary care physicians have said, well, you know, if I'm going to get back in this business, I need more training. I just don't feel comfortable with what I'm doing here. So, I want us to talk a little bit now about treating chronic pain in a primary care office. Joel spent a good deal of time talking about team-centered care. I've been a big proponent of patient-centered medical homes for a long time. And in ideal patient-centered medical homes, the team that we surround the physician with is an embedded mental health counselor, a PharmD, physical therapist, a dietitian, and a nurse care manager. Unfortunately, in this country, this patient-centered medical home is given a lot of lip service to, but they don't provide us with the funds to flesh it out. So over 15 years, I've had various components of this team in my office, and I've had to pull it back as we couldn't afford to pay for the services anymore. On average, people in primary care treat 5 chronic conditions in one patient, and you see, 25 or 30 of those every day. COPD, coronary artery disease, mental health disorders, diabetes, hypertension, the list goes on and on. And we've become very good at managing chronic diseases, multiple chronic diseases in one patient. And we've become very good at that because of this team that we've put around us. I would say of all the people on this team, the one that's been most valuable to me is the mental health provider. And then in addition, and this is true of any chronic disease, there are some people we need help for. And the patient-centered medical home is the center of a wheel. And we go out periodically and look to specialists to help us with difficult problems that we can't take care of ourselves. And that certainly is true in the chronic pain arena. We use pain specialists, we use psychiatrists, we use specialists in addiction medicine, and the whole thing should be synchronized and coordinated by the primary care physician. Ideally, we should have a primary care physician for everybody in the country. That's the model that's used. I work with a lot of people outside of the United States, and that's the model that they use. In addition, everybody has health insurance, but that's a whole nother discussion. So I'm not going to go into this too much. I just want to tell you a couple things. I had a friend probably 5 years ago, and he called me. He was a physician colleague friend of mine, and he said, Ed, the medical board called me yesterday, and they want to come and interview me about my narcotic prescribing habits. And do you have any tips for me? And the first question I said, do you have a chronic guideline set up for pain? And this isn't any different than the chronic guideline we've got for diabetes or hypertension or congestive heart failure. They're just, it's good medical practice. And he said no. And he also said, I feel it's an affront to the patient-physician relationship, and I know my patients, and they would never lie to me. And I thought, well, there's the problem right there. So I suggested that he might want to consider doing this. and I don't think he ever did. We actually, in one of the hospitals I'm a staff member of, we had a pain medicine specialist, one of the best anesthesiologists I was ever associated with, that ran a pain clinic. And the hospital was, again, trying to institute this chronic pain management guideline. And he was very resistant in the same thing. I know my patients, they would never lie to me. Well, I'm here to tell you that perfect world, maybe that's not true, but patients lie to me all the time. When I put this guideline in place, and initially we talked about it, and I say, look, this is to protect me from putting drugs out on the street and putting them in the hands of people that use them for nefarious purposes. It's also to protect you so you can keep getting your drugs. And when you put it in that sort of venue, they understand. And then I'm not going to go over that. This is something that came out of the CDC guideline in 2016 in the North Carolina STOP Act. These are things that you need to do at the end of each visit. And I think most of us know about what the documentation requirements are. So I had some training in anesthesiology years ago, and when I started doing this chronic pain management, over the years I've learned a lot of lessons which I'll pass on to you today. And the very first is a narcotic should be the absolute last thing that you try to treat pain with. And unfortunately, a lot of physicians over the years have said, oh, you've got pain, well here, why don't you take this, and they're out the door. And it's easy, it's 5 minutes, they still get their money. Probably takes me at least a half hour to really evaluate somebody that's got chronic pain. And it's not easy. And you want to do it the right way for the right reasons. So I've used all of these things that you see. The sad thing about it, in the colleagues that I have in Canada, in New Zealand, in England, and Belgium, and Germany, and France that I've worked with some, all these things are paid for by the health insurance. In this country, it's not. I find deep tissue massage therapy is a wonderful modality to treat a lot of pain, but it's $80, a session. A lot of people on fixed incomes can't afford that. So what I have found to be, as I've done this over the years, what I found to be really helpful is physical therapy with stretching, muscle strengthening, getting people to lose weight and stop smoking. If I could take those things out of all of these, I think they're the most important, and then you don't have to use the narcotics. But I will even go so far as to say, surgery is definitely an option for some people to treat chronic pain, as radical as that sounds, but it's a very valuable modality in the right hands. But please refer patients to surgeons that are very conservative. One of the reasons, I'll tell you a quick story. The National Institute of Medicine a few years ago put together a blue ribbon panel of specialists to look at back pain and surgery. Neurologists, orthopedists, chiropractors, neurosurgeons, mental health people, the whole 9 yards. They said that 90% of back surgeries in the United States would probably should have been done. And unfortunately, a lot of things that we do in this country are done because we get paid for doing surgery. I hate to say that and admit that, but it's unfortunately true. So Steve talked about some of the red flags, and some that I've come up over the years. Alcohol use, huge. Diabetics, they have a lot of pain problems. But one of the things that really creates problems for them is that they have autonomic nerve damage, which affects the nerves that line the intestinal tract. The intestinal tract doesn't move very well, and when you put a narcotic into that mix, the intestinal tract stops. And so these people end up coming in, revolving door to the hospital with repetitive vomiting that goes on for 4 or 5 days, and it's just a nightmare. So you don't want to do that. Family history is really important. Nicotine addiction, like Steve said, huge. And then mental health disorders. So one of the things that I started doing, I started using screening tools in my initial assessment. And the first screening tool that I used was the PHQ-9 for depression. Then I got to thinking, I said, well, why don't we add one for anxiety? So I did that. And then I found out about a study in the Kaiser system in California that talked about adverse childhood events. And I'm going to go into that in detail because it's just so important and under-recognized. And then 2 years ago, the American Academy of Family Practice came out with a screening tool for the social determinants of health: food insecurity, homelessness, lack of jobs, lack of income. You can't treat any of these people that are living under a bridge somewhere, And then what do you do to help people with some of these things? Interestingly, in the U.S., if you took the money that you spend on a social determinants of health and you put it together with the things that you spend on healthcare, hospitals, physicians, those sort of things, and then you look at that same metric in the rest of the Western world, we spend 1/3 of our money on health, hospitals, doctors. I'm sorry, we spend one-third. No, we spend 2/3 on health. I'm sorry, and 1/3 on social determinants of health. In the rest of the developed world, they spend 2/3 of the money on social determinants of health and 1/3 on health care. And they have much better health care outcomes than we have as a result. Unfortunately, in this country, social determinants of health are looked upon as socialism. I'm not going to get into the politics of this, but it's true. The Adverse Childhood Experiences study came out of the Kaiser Foundation, and several years later, the CDC has, because it's become such a powerful study, they partnered in with them. And what happens when children undergo adverse childhood experiences, this sets up a very disrupted neurodevelopment within their brain, things that Steve talked about. And then, as they get to be older children and adolescents, it creates a lot of social, emotional, cognitive impairment. They don't even realize where it's coming from. And they start adopting risky behaviors. Teenage pregnancy, they eat too much, they get obese, they smoke, they drink, they start using IV drugs. The list goes on and on. And as they get into their 30s and 40s, they start accumulating chronic diseases, emphysema, heart disease, depression, suicide, and it leads to an early death. And I'm not going to go through all of it. This is I think it's a 12 question, and each question has a point. So did parent or adult in the household swear at you, insult you, put you down? Anybody touch or fondle you? Did you not ever have enough to eat? You wear dirty clothes, you know, and so you kind of get the idea. So at the end of that, you score, and the score is 0 to 12. And what we found is there are 40 outcomes to date that correlate with the ACE score. If the score is 6 or higher, you have a 250% chance of smoking, which leads to an increased incidence of lung disease. 500% increase in alcoholism. If you have a score of 6 or more, this one really struck me, 4,600% increase in the use of methamphetamine and heroin. And to Steve's point, you know, I still work at the hospital, and the only time we saw IV problems related to medicine, and I was in an inner city at the time in Detroit. You know, we would see people with bacterial endocarditis. We'd see people with sepsis. We didn't know what HIV infection was at the time. Hepatitis C wasn't really. There was another hepatitis, but we didn't know what it was. Well, now we're seeing these things in community hospitals. You know, the incidence of hepatitis C is going up. Fortunately, we've got a drug to treat it. Of course, it's, you know, $23,000 for treatment. HIV epidemics are starting to rise again. Diseases like syphilis, gonorrhea are going up. And we never used to see endocarditis in community hospital settings. We're seeing it a long time now. So all of this leads to all sorts of chronic diseases. Heart disease is another big driver. Other issues, obesity, absence from work. If you had a score of 6 or more, you had a teenage pregnancy rate of 53%. Fetal alcohol syndrome. So, on average, the people in this scenario may die at the age of 60. The average lifespan in the United States is 79. So, in primary care, we should hold these people. But we've got things that we can offer them through patient-centered medical homes, but we have to identify them. So I'm going to quickly talk about, and we can talk about this more at the break or in the afternoon if you want to come up and talk to me about it. I just want to talk a little bit about how we can incorporate medical-assisted treatment into a busy primary care office. And the only reason I put this slide up here, I want to echo what Steve said. This is a very safe drug. And it's really easy to use in an outpatient center. And Steve talked about, you know, buprenorphine being a partial agonist, and that's one of the reasons why it's so safe. You just don't see a lot of respiratory depression with it. And you don't see a lot of the problems with narcotics that come with the full agonist new receptor drugs like morphine or methadone. So when I saw a patient yesterday that was referred to me that's been having addiction problems, and I do a lot of the same things that I do for patients that are treated with chronic pain. We start out with an educational material, and I try to bring significant family members into this too, because there's such a stigma. You know, the families don't understand it at all. And you have to kind of bring them around, and a lot of times the patients have hidden this from their families, wives, moms, dads, etc. So you've got to break that down. And then we sign a patient contract again. You know, I mean, I'm a trusting guy, but you get burned. So you want to make sure that, people know you're going to do a random urine drug screen, maybe we're going to count bills, those sort of things. And I use the same screening tools that I use for chronic pain. And they've been really valuable in picking up some things that I need to key on from the get-go. I also just give them a list of prices in the area for the Suboxone products. Unfortunately, I found that as Suboxone has become more popular, it's increasing in price. And a lot of these people, haven't had jobs or are using money from relatives to help get them through this. So the way I do this is I tell them to stop their narcotic Saturday evening before they come and see me on Monday, because I want them in a little bit of withdrawal. And then I have them seen 8:30 Monday morning, and we start titrating, and we usually titrate Monday, Tuesday, Wednesday, and Thursday. By Thursday, we usually have got them on a dose that is reasonable and they feel comfortable on. And the nice thing about this, I can go about seeing patients that morning, and I'll just come back to them and say, how are you feeling? And, okay, we'll stop today, come back tomorrow. So you can sort of multitask and do this while you're seeing other people. And then I see them weekly for a few weeks until I feel comfortable. And the other thing, this is true of chronic pain, everybody gets a mental health consult, and it's non-negotiable. If they don't do it, we don't have a relationship, we're not going to do any business together. I just want to talk about, these have become, I used to do obstetrics, very rewarding part of my practice. These people have become as rewarding to treat as the obstetrical people that I used to see. This is a disease, it's not a moral failing. So the first person I treated was a 28-year-old heroin addict. She started using heroin when she was 18. Her dad was a heroin addict, so it was in their genetic makeup. She eventually got into a methadone clinic. She just didn't like the way it made her feel. She came in 2 years before I started using Suboxone. She said, I want off methadone, and I tried monthly IM naltrexone. Didn't work for her at all. She went back to the methadone clinic. She came back in, and I had 6 months before gotten the Suboxone license, and titrated her through this process I just described. And by the 4th day, she said, I feel like a normal person. I feel like I got my life back. 2 months later, she said, my mother's given my child, my 4-year-old back, because I can take care of the child now. And 6 months later, she had a full-time job. She hadn't had a job in 10 years. And she has a full-time job today. The second was a 63-year-old methadone clinic patient. Again, it was referred to me by her sister, who was a nurse, and said, she's just not feeling well on methadone. And she was one that had back surgery and then got on the road to addiction through the back surgery. So I saw her, and through the screening processes, I realized that this lady is depressed. She's really depressed. So we got her on an antidepressant and got her to see a mental health provider. And then, when she was better, we weaned her off the methadone, put her on Suboxone, and she's never looked back. 45-year-old was referred by somebody, had neck and back pain, and went down that road toward addiction. And he was married. Marriage was a little dysfunctional. He had children and grandchildren. He said, I'm going out on the street. I'm afraid to death that I'm going to get Percocet laced with fentanyl and I'm going to be dead. And I've got to get off this treadmill. And so we went through that, and he did really well, and he feels like he's got his life back. And then one day he came in and he said, you know, I'm a big golfer, and I went and shot a 74 today. And he said, I haven't shot that in 10 years. And I said, well, I don't think the spot zone did that. One other thing I want to say that I work in a hospital setting. We're probably going to see more of these people. And people that are involved in multiple trauma or have large incisions on their chest or abdomen, there are problems and they're on Suboxone sometimes controlling their pain in the hospital. Some of these people have required industrial doses because of the fact that Suboxone holds on to that new receptor so tightly. So you really have to get together with the provider in the hospital and the anesthetic team and maybe the addiction medicine team to sort that all out, because it can be a problem. So I know my time's up, but I wanted to talk about this for 2 more minutes, and this is going to sort of be a bridge to what we're going to be doing in the afternoon. So I heard Stephen talk about this a little bit, but there are a lot of people, and this actually is, they're thinking in the National Institutes of Health about the opioid epidemic like they dealt with the HIV epidemic. And there are a lot of similarities. You know, uniformly killed people a lot. There was a cultural stigma to treating HIV infection initially because it was, in this country, it was thought to be basically a disease of the LGBT community, and of course they deserve this for the kind of activities that they were involved in. And then we come to find out, you know, that this is a heterosexual disease that has, you know, affects everybody. And initially there was little or no funding for it. And it didn't get any traction politically until people like Magic Johnson and Arthur Ashe came forward and said, you know, I've got the disease. And the HIV community did a marvelous job of taking an epidemic that was killing literally everybody that got the disease and making it chronic, manageable disease that nobody dies from anymore. So, medical assisted treatment, it's a big part of the solution. You know, if we build it, they're going to come. 80% of addicts receive no treatment because of cultural, social, economic, and structural barriers. We've got to address the structural drivers, eroding economic opportunities, market-driven health care, where people don't have any insurance, they don't have, drugs are expensive, they can't afford them, insufficient regulation of pharmaceutical markets, look at evolving approaches to managing pain that don't involve narcotics, and correct the limited effectiveness of drug treatment. We need to reduce the stigma and focus on community and societal norms where they're trying to change individual attitudes. And that includes physician providers. Legislation's got to stop criminalizing substance abuse disorders. 75% of all the people that are in federal prisons are there because of something that has to do with substance abuse. I had a conversation with the sheriff of Burke County, and that I hope is going to be here this afternoon. He said that 95% of all the people in the county jail are there because of something that has to do with substance abuse. He also said that an addict is responsible for 12 property crimes a year. You treat one addict and you take 12 property crimes out of your community. And then we need to start anti-stigma training for truth police, healthcare providers, mobilize support for family and community networks, community activism, and really look at city and state governments who could invest money to help implement a lot of these community-based programs.
Okay.
And that's it.